the theme of the meeting is PD for all. But then I looked at your slide presentation, I saw the first slide and I thought, is it really PD for all? Does this guy actually believe what the whole ethos of the meeting is around?
No, I crossed it out because like most things in life, there's usually not one treatment that suits all individuals. So I think PD is the same. I think that choice of dialysis modality is very much a shared decision involving the physician and patient, and PD isn't always the optimal choice. But I do think PD is underdone, and we could do a lot more. And I think the thrust of my talk is really focusing on the sorts of characteristics of patients that might make it more suitable or amenable for doing PD. And I guess the other important thing is trying to optimise PD outcomes for all patients, because I think particularly in our area of the world we tend to do it fairly poorly.
So registry data is obviously key in your presentation, and it's something that you've pioneered. We'd be very interested in Europe to understand how you've managed to do something so complicated. So what were the real main barriers to setting this up, and what can we learn in Europe from your experience?
The main barrier is firstly culture. You need absolute buy-in from all stakeholders, and you have to be able to do that, you've got to have an expectation that doing registry data and audit is part of the core business, in provision of service to patients. And also ensuring that the amount of data that you collect is not so onerous that people refuse to do it. So you have to have that sort of compromise between getting a good breadth of coverage, but not so much depth of coverage that you don't get absolute buy-in from everyone.
And so where's the biggest block? Is the biggest block at the level of the regions, the countries, of course, across the divide to New Zealand, your popular foes across the way? Or is it at the level of the nephrologists?
It's at the level of the nephrologists. It's even more than that, because different units have different amount of staff support for ANZ Data Registry. In some units, the nursing staff are the ones who predominantly fill out the forms. In others, it's the nephrologists. Some units have data managers, and therefore it's easy for them to be able to contribute to ANZ Data, whereas others don't. But I think one of the things that's unique about the ANZ Data Registry is that since the first dialysis in May 1963, we have captured every single patient from every single unit in Australia and New Zealand, which I don't think has been done by any other disease registry in the world.
No, I think we're very, very jealous about that, one has to say. And I think that, does it identify that, part of this, is a philosophical question, but part of it really is a logistical question of providing people with the tools, convincing them of the quality of the data will have a positive impact on the therapy. But really there's a huge element there of logistics and operational things and underpinning your capacity to do this.
Yep, absolutely. Like I said, I guess the burden of data collection has probably been our greatest problem, and the way we...
I hear a phone sound in the sound.
Oh, maybe I've got that switched. Do you want me to switch it off?
Yes, if it's possible for...
Sorry.
No problem.
Was there a problem all the way through?
No, it was just...
Only the...
Just going off, was it?
You better repeat the question.
Okay.
So logistics is clearly a key issue here, and you talk about the ability of different dialysis units to deliver the data. So how have you addressed that issue in Australia and New Zealand?
We've done it in several ways. Firstly, we have a rule where we fit it to one A3 size sheet of paper, and we have now a set number of fields. I think it's 65 or 66 data fields, and it's divided up between peritoneal dialysis, hemodialysis and transplantation. This number of fields is set so that any particular group wants to add data, they've then got to also suggest what comes off in its place so that we keep the same amount of overall data collection the same. The other big issue we had not so long ago was in 2001, national privacy legislation was a big threat to the ongoing function of the registry. The way we've got around that now is we have an opt-out scheme. Every patient coming onto renal replacement therapy who gets registered with ANZ Data gets given a patient information sheet. We've had approval from every ethics committee in Australia and New Zealand, and And now patients, the default is they're in the registry unless they specifically request not to. And thankfully we haven't had patients want to opt out, so we can still keep that going.
And then obviously the other barrier is financial. And so,
Yep.
so if you think of it in terms of, you know, dollar per patient or dollar per region, what's the total amount of money that you think you've spent on this registry since its inception?
It's hard to know. I can tell you that roughly the registry operates on about 300,000 Australian dollars per annum. And that comes from predominant contribution from Australia and New Zealand governments in proportion to the number of patients contributed. There's also some funding from non-government organisations like Kidney Health Australia, although that's fairly limited. There is industry funding, but not. There is a policy in the ANZdata registry that's not for the core activities of the registry. If there are special projects, for example, there are scholarships or fellowships with ANZdata for people who want to do epidemiology or biostatistics training. We're happy to have that industry sponsored, but not core registry activities. So funding is difficult. It's sufficient at the moment to be able to do what we want to do with renal replacement therapy. Several years ago, we wanted to expand to include CKD, pre-dialysis patients, but that would have required many millions of dollars per annum to be able to do that.
So $300,000 Australian dollars, as that is, you know, is not a lot of money in the context of healthcare. So if I gave you 5 million Australian dollars, how would you spend it in this context?
Well, we would move into CKD, probably stage 4 and 5, pre-dialysis CKD would be how we would move.
And where do you stand on biomarker studies or looking not only at collecting clinical data on these patients, but actually collecting biosamples?
That we would envisage that would probably be difficult to get 100% buy-in, and if it's a threat to that, we usually don't go with that in ANZdata. It needs to be something that's fairly simply collected and able to be collected by every unit participating in ANZdata.
Okay, David, thank you very much. Enjoy the rest of your trip.
Thank you.